studying Antiparkinsonism drugs, and we started, of course, with what the disease, what is the nature of the disease, what are the symptoms of the disease, and of course, we did mention that even for the drugs that we are giving, it is just to give quality of life, managing the symptoms, and but because we do not cure this disease, and we did give a long class about six classes of Parkinsonian disease, anti-Parkinsonian drugs, and of course we started with we had the cholinergics. And I think we discussed the cholinergics, including the anticholinergics, and of course also the cholinesterase inhibitors. And I think we started on dopamine release agents. Perhaps you can advise me on which was our last slide. I think you were on dopamine releasing agents, if I'm not wrong. Can you help me remember which was our last slide? So we should have a class tomorrow, because I think there are some students who will be starting on their, just 1 minute. So there's a group, I think my group, we are supposed to do our project presentations on Thursday. So I had also requested earlier that we can be having an extra lesson on Wednesday. So because of that also, we must have our class tomorrow on anti-cancers, because I think they are the same students who are doing the presentations. So we might not be able to have our class on Thursday morning, not unless if you have some time, you can slot it in the afternoon, because we'll be having presentations in the morning. So tomorrow tomorrow you will tell me what time before we finish, when we can have our cancer class. Because if we don't do so, we will not manage to finish, and we do require to finish, because we still have our antivirals. Thank you. You are telling me we've gone as far as metabolism of L-DOPA, then we are doing well. So as I was saying, we looked at the dopamine releasing agent, amantadine. We looked at amantadine, and then of course I think from releasing agent we went to dopamine replacement, where we did mention, of course, we cannot give dopamine as a drug, and we said, of course, it will have a lot of toxicity in the periphery. It has high water solubility. It is polar, highly metabolized. It cannot cross the BBB. So in other words, therefore, we must have a replacement of dopamine to be able to give it as an oral drug. And once we give it, we hope that it can get into the brain. And that's why we started with L-DOPA. And we said L-DOPA, of course, also will undergo a lot of metabolism, because we have the L-DOPA decarboxylase. We have the L-DOPA decarboxylase within the periphery. And because we have the decarboxylase enzyme within the periphery also, the L-DOPA will undergo decarboxylation, and therefore still give us dopamine. Therefore, we still expect toxicity even when we give L-DOPA on its own. And therefore, after that, we are going to look at what can we do again to preserve this L-DOPA so that it can get into the brain. And within the brain, where we also do have the L-DOPA decarboxylase, then we can have that the L-DOPA undergoing decarboxylation in the brain near the site of action, minimal toxicity, increase the levels of dopamine, and of course you deal with the symptoms. As we said, we are not treating, of course, bringing a balance between the acetylcholine and the dopamine, and then of course therefore relieve the symptoms of Parkinsonism, because as we already said, that is indeed what we are trying to do. So therefore, let us finalize. I believe we were able therefore to look at metabolism of L-DOPA. Yes, this is where we were, and we were able to look at this. And when we look at the metabolism of L-DOPA, we can see we do have about three major enzymes. Of course, we have the catechol-methyltransferase that will methylate the 3-hydroxyl group within DOPA. And of course, within L-DOPA, we also do have the aromatic amino acid decarboxylase enzyme that will synthesize DOPA, and it can synthesize DOPA in the periphery, as we have said. We don't want it synthesized in the periphery. Then, of course, the L-DOPA, using transporters, will be able to cross into the brain. And again, we have the same enzymes. We have the COMT, which will terminate the activity of course, the L-DOPA. We have, of course, also the decarboxylase enzyme, which will give us the dopamine now in the brain. But of course, also the dopamine can be metabolized by, again, the monoamine oxidase B, or the COMT, or catechol-O-methyltransferase. And because of these specific enzymes, we are able also to synthesize drugs that can target these enzymes. Therefore, we see that we can have monoamine oxidase inhibitors to try and block that enzyme. We will also see that we can also have catechol-O-methyltransferase inhibitors in trying to minimize the metabolism of dopamine, so that we increase the concentrations of dopamine in the brain, and therefore help us relieve the symptoms of Parkinsonism. So, of course, the only difference is that here we are starting with monoamine, and on the other side we are starting with catechol-O-methyltransferase. Of importance to note is that we do have two types of monoamine oxidases. So in the brain, we have the monoamine oxidase B, and in the periphery we have A. So we'll be looking for drugs when we look at for inhibitors of the monoamine oxidases. We'll be looking for drugs that can specifically target the monoamine oxidase B, so that we can have minimal toxicity. Always remember, the more selective a drug is, the lesser the toxicity. So I think now we are all together, and we are reminded of what we had discussed last time. So we had, of course, said addition of a DOPA decarboxylase inhibitor, carbidopa, will improve the CNS bioavailability of L-DOPA. So that's just what you need to do. You need to look for a compound that can block the periphery decarboxylation of L-DOPA, minimize the toxicity, increase the concentration of L-DOPA, get it into the brain, and therefore give you activity. Of course, that carbidopa, that compound should not also go to the brain. It should actually be left in the periphery, because if it goes into the brain, then it will also interfere with the availability of the dopamine. So you can see that happens in the periphery. So within the periphery, you give this compound, again, you can see there is structural resemblance of carbidopa. There is some slight structural resemblance of the carbidopa with the dopamine. Of course, there is structural resemblance, and there is, of course, a structural difference, because we do remember this is supposed to be acting as or antagonizing the DOPA decarboxylase enzyme, and therefore when it binds, it should bind more strongly and prevent the L-DOPA from binding on that side. But you can see that is a catechol. You can also see you still have the tertiary amine, and you can see one carbon 1, 2, and that amine. In fact, what has happened is that there is more substitution. So at this position here, there is a substitution at that position, and also this is a secondary amine, not a primary amine. So a bit of substitution, making the molecule more bulky, giving it more binding onto the receptor, and therefore blocking the DOPA decarboxylase, and hence giving us higher concentration of the dopamine within the brain. It is absorbed from the small bowel. Peak plasma levels are that, and may be delayed in the presence of food. The rate of absorption of this L-DOPA is dependent on the rate of gastric emptying, the pH of the gastric juice. Why would it be dependent on the pH of the gastric juice? Why will it depend? The length of time the drug is exposed to degradative enzymes of gastric mucosa and intestinal flora. Of course, we did mention there can be, this is a compound that can undergo fast metabolism, so the longer its exposure, so you want it to be absorbed very, very quickly, and you can see it is absorbed from the small bowel. And why from the small bowel? Remember, as you go down, the intestines become a little bit basic. If you look at this drug, these are basic drug. Basic drugs are non-ionized in basic environment, and of course non-ionized drugs are better absorbed. And that is why we are saying pH of the gastric juice. If the pH is very high, then this drug will be protonated. And of course, there will be very poor absorption. Or is it, if the pH of the gastric juice is very high, even as even as the contents of the stomach empty into the small intestines, they'll still be carrying very high. They will not be completely neutralized. So they'll still have some acidic pH, and therefore will have a negative influence on the absorption of these drugs. So that is because, as we have already known, non-ionized drugs are better at penetrating the lipid membranes than ionized drugs. The drug is extensively metabolized in the periphery and by the liver, very low amounts, very little. This we have also said will get into the brain unchanged. It penetrates the CNS, and we have said it has a very short duration of activity. It is excreted primarily in the urine. The major urinary metabolites, we are still on levodopa. We had said it is metabolized very rapidly in the periphery, and therefore very short duration of activity. And the main metabolite is the dihydroxyphenyl acetic acid. This is that one. And the homovanillic acid. We had already looked at its metabolism. So you just need to, this is the metabolism we are talking about. You have the L-dopa going to dopamine, and then the monoamine oxidase is converting it to the carboxylic acid, and the carboxylic acid, of course, undergoing methylation at position number 3. So when you remember that, when you know what is happening, it is very easy to derive the products of metabolism. So what are we talking about treatment? This is levodopa. So you can see this is our levodopa here. It can be metabolized. The levodopa can be metabolized through catechol-methyltransferase to give us the 3-methyl. We can actually call it the 3-methyl levodopa. 3-methyl levodopa. All 3-methoxy, 4-hydroxy phenylalanine. We can also call it a phenylalanine. So we can also call it 3-methoxy, 4-hydroxy. Here, we will call it 3-methyl levodopa. 3-methyl levodopa. So that levodopa, as we have said, is acted on. This is what we have said, acted on by the decarboxylase. And of course, once it's acted on by the decarboxylase, it will give us the dopamine. And this dopamine, you can see, is what is being absorbed or moving into the vesicle, and therefore giving us good activity. When of course, some of it is absorbed, getting into the vesicles, and is responsible for good activity. But you can see how extensive, as you've already said, the metabolism is highly extensive, and therefore, especially as we said, especially through the decarboxylation in the periphery. And that's why we said you will be required to give the carbidopa to assist us. So carbidopa, also levodopa, I mean the enzyme, the levodopa decarboxylase uses pyridoxine as a cofactor. So the carbidopa also pyridoxine, and therefore traps the pyridoxine. And the pyridoxine, remember, the pyridoxine is joined to the decarboxylase. So the decarboxylase enzyme is joined to the pyridoxine. So now the carbidopa comes and binds the pyridoxine, which is bound to the decarboxylase enzyme, and therefore it traps your decarboxylase enzyme. It is not free for activity. So that's all we are saying, that it is, carbidopa is a pyridoxal, trapping a pyridoxal dopa, decarboxylase cofactor trapping agent. It is a dopamine decarboxylase inhibitor. I think this or that it only blocks metabolism outside the brain because it cannot penetrate the brain. So that is of advantage, because if it penetrates the brain and gets into the brain, then so it will be left in the periphery and therefore will only stop the formation of dopamine in the periphery. So this we are calling the carbidopa. So you can see this is our enzyme. This is our pyridoxine, and that is our enzyme. So they are attached together. So when the carbidopa comes in, it also binds the pyridoxine. So that's why we are saying it is a carbidopa. It is a pyridoxine dopa decarboxylase trapping agent. It is a pyridoxine dopa decarboxylase trapping agent because it traps both of them. And when you look at pyridoxine, that's the pyridoxines, you can see, you look at the carbidopa, it has NH3, so it is a hydrazine there, very binds on this other side of the carbidopa, and the three, it's like a ternary complex where you have the dopa decarboxylase, you have the pyridoxine, and you have the carbidopa, and therefore the enzyme is not free to do peripheral decarboxylation of L-dopa. And I think that finishes the replacement agents, and because these are not hard things, we move to the next one, which is dopamine receptor agonists. And so we have looked at replacement, where we are replacing the dopamine. We have looked at releasing agents, whereby the dopamine is being released by the compound getting into the vesicles and releasing. And of course, we did say that what are the disadvantages and so on. Now, the other one is the dopamine receptor agonist. When you talk about agonists, these are compounds that are structurally similar to dopamine and will go for the same receptor. So they will act like dopamine, and hence, therefore, bring about pharmacological activity. So they will reinforce dopamine neurotransmission in the substantia nigra, postsynaptic receptor activation. They will reduce also dopamine biosynthesis and turnover by activating presynaptic autoreceptors. And the classification is, we have about two main classifications. We have the ergoline or ergot derivatives, and these are usually bulky. These are usually bulky and naturally occurring derivatives. So all ergoline derivatives are structurally derived from alkali products produced by that fungus. So they are naturally occurring, all semi-synthetic. Natural and semi-synthetic compounds having high affinity, both agonistic and antagonistic, for monoamine, noradrenaline, dopamine receptors. So they can, some of them can be can have agonist antagonist activity, but of course you'd want to go for the ones that have very good agonist activity. We do have examples of bromocriptine, and the more potent also pagoline, but pagoline unfortunately has been withdrawn from the market. I think it had serious side effects, and it has been withdrawn from quite a number of markets. They are dopamine receptor agonists used as adjunctive treatment to levodopa in controlling the symptoms of PD or Parkinsonism. So all we are saying is that you give them, and they will trigger the release of dopamine as adjuvants, and therefore you will give them together with levodopa. You give them together with levodopa. Affinity of ergoline derivatives for dopamine receptors is presumably related to the presence of an allyl ethylamine structure feature in these compounds. In other words, there is structural resemblance. When you look at the structures, that is all we are saying, that there is an allyl ethylamine structure. And if you look at this ergoline, if you look at the two, as I have said, one, they have complex structures. If you look at the compounds that are ergoline or ergot derivatives, we have bromocriptine. And all we are saying is that if you look at that structure, you will be able to see this. You see, this is all we are talking about. You look at this. So this one here. If we go that way, up to there. So you can see when you look at dopamine, it has that aryl group. That's why we are saying aryl, ethyl, 1, 2, ethyl, amine. So we are saying their ability to bind the receptors and have some dopamine activity is because they have this section within them. They have that section, which is the aryl ethylamine structure, also found in dopamine. It's of course also that when you look at them, they have also the bulky groups, and I believe the bulky groups are only to help them bind the receptor, anchor them well at the receptor site, and they bring about the pharmacological activity. That's why some of them will also have antagonistic, will have agonist antagonistic activity because of the very bulky structure. So if you look at bromocriptine, again, you can see this is our, there is our aromatic group, aryl group, and we go like that. And you can see it has that structural resemblance with dopamine, and that is what we are saying is giving it the activity it has. And of course, also the same case applies to this compound there. So we can move on again like that. So you find that structural resemblance is what is giving those compounds the ability to bind dopamine receptors and indeed to activate those receptors and of course give us activity. But of course, these compounds also have been found to have a lot of other pharmacological activity. They do not have selectivity for the D2 receptors, and therefore, and of course, with the emergence of better drugs, you will find that you will not really use them because they will have a lot of toxicity. So bromocriptine is an ergoline derivative. It's a dopamine agonist that is used in the treatment of Parkinson's disease. It is a dopamine that activates, of course, used with levodopa, carbidopa to prolong the effectiveness. So you can't be able to use it in combination. So you find that for Parkinson's disease, for us to achieve good results, normally you do combination therapy. Of course, remember when you do combination therapy, you will reduce the toxicity of the individual drugs because you use each individual drug at much lower toxicity. You can also increase toxicity because you're exposing that patient to more than one drug at the same time. But we expect that when you use combination therapy, you will reduce the individual doses and therefore reduce the toxicity of each of the individual drugs at every one time. Of course, we also believe most of them there is synergism and all those things about combination therapy. Then we do have the non-ergoline derivatives. So we have pagoline and bromocriptine for ergoline. And as I have said, pagoline, I think, has. And of course, these ones will be simpler in structure. They'll be simpler in structure, but they must also have some structural resemblance with, of course, dopamine. So there will be structurally simpler dopamine receptor agonists compared to the ergots or ergoline derivatives. The spectrum of receptor activities is much more focused than the ergots, leading to lower toxicity, lower interaction with serotonin and noradrenaline receptors. All we are saying is that they have more selectivity. As I had said, bromocriptine, you find it binds many other receptors and therefore it will bring a lot of toxicity. So now the development of the non-ergoline derivatives was to come up with more specific, more selective drugs that will go for the dopamine receptor, trigger the dopamine receptor or activate the dopamine receptor and increase the dopamine concentrations. As we have said, of course, there will still be structural similarity with dopamine. You can see we have that group there. You can see it going that way. And of course, that gives us structural resemblance. With dopamine, of course, you can see the very huge substituents that are on the nitrogen as opposed to the hydrogen atoms that are found on dopamine. So you can see it is just a matter of you have the basic dopamine molecule and it has been made a bit bulkier. There is substitution on the terminal nitrogen, substitution on the terminal nitrogen with the huger alkyl groups to give that molecule better lipid solubility, of course, to be able to penetrate the BBB and so on. So, of course, also you have the pramipexole dihydrochloride. Again, do remember most of these drugs are given in their salt forms. They are given in their salt forms, and so that you increase their water solubility. Again, if you look at that compound, here the benzene ring, as you can see, a benzene ring here has been replaced with a thiazole ring with retention of activity because we do know that the thiazole ring is an isoster of the benzene ring. And because if you look at that, so that is our aromatic group, aryl aromatic group is here. And if we look at, we can move that way, we come this way, and we get to our nitrogen there. And you can see this one, that's our thiazolene 1, 2 carbon atoms. So the structure of dopamine is still retained, where we are saying the benzene ring has been replaced with a diazo ring, which is isosteric with retention of activity. And then you can still see there is a ethyl 1, 2, ethylamine. And of course, your nitrogen has been substituted with this bigger group. One of the hydrogens has been replaced with a propyl group with, of course, increasing lipid solubility and, of course, better penetration of the BBB. So those are the two drugs that we are calling the non-egoline derivatives. We can say something about them. If we look at the pramipixole, this is a pramipixole. It's a tetrahydrobenzothiazole. Benzothiazole derivative. It is formulated as the di-HCl. In other words, you add 2 moles of, for every 1 mole of this drug, you add 2 moles of HCl. This is because it is able to exist as this tautomer. You can see this tautomer, whereby you form a double bond. You form a double bond at this point here. You can have that lone pair of electrons coming in, form a double bond there with the loss of a hydrogen. Once you have that, then this nitrogen is basic, and also that nitrogen there is basic, giving us 2 points of protonation, and therefore that drug being a diacidic, or being dibasic rather, dibasic, and therefore it can be able to react with 2 moles of acid. So therefore that's why they're saying it is formulated as a dihydrochloric acid salt at the NH, that is at the side chain, that's the side chain NH. Sorry, so it's not this one. Sorry, I'm sorry about that. Could be this one. Sorry. So at the side chain NH, which is that one, and at the heteroatom, that one now. So because this one is the one which is most basic, it has no double bond. So at that heteroatom NH and at the side chain NH, then those are the ones that are protonated at physiological pH. All when you give it as a salt, the acid will react with those 2 basic nitrogens. It also exhibits stereochemistry. If you look at this carbon there, that is a chiral center, and we are saying so it is pharmacologically, it has an active it's a active single stereoisomer, and the S-levo totally isomer is the one which is active. It is the one which has higher affinity for the D2 receptors family. So we are saying therefore, and we can see the stereochemistry in drugs is not anything new. So we can't see that point. That's one substituent, another substituent, another substituent. So it has one chiral center, and it can have stereochemistry. It can exhibit stereochemistry with the pharmacological isomer, being it is only one isomer, which is the S-levolatory isomer, which displays activity. It has a low oxidation potential. If it has a low oxidation potential, it means that it can be oxidized easily. It has a low oxidation potential, or it can act as a reducing agent. So it has a low oxidation potential. It can act as a reducing agent. It can be easily oxidized, and therefore, if you have any free radicals or any anions or any electrophiles, it can be able to react with electrophiles. It can be able to react with radical or superoxides, and therefore, and as we were looking at the anti-cancer drugs, we did mention about superoxides. We did mention about free radicals being known to cause a lot of toxicity. So it's able to mop up. It can be able to mop up free radicals. It can be able to mop up electrophiles and so on, and therefore, and that is one of its way of activity. It possesses a low oxidation potential. Of course, That's an added advantage because it is binding. It is a dopamine agonist. So in addition to it being a dopamine agonist, it also can act as a reducing agent. So to be oxidized and act as a reducing agent for neuroprotection, agent for dopamine-derived free radicals and electrophiles. So that makes it also have an added advantage on top of course, it being an agonist. So that is just an added advantage, that it has low oxidation potential, and therefore it can act as a scavenger, whereby it is mopping up any free radicals or any free radicals, all any electrophiles, and hence protects the body from toxicity. So some of the oxides, so you can see dopamine in the body can undergo oxidation to give us the quinone, can undergo oxidation to give us the quinone. And of course, this is a very potent electrophile. And of course, in that process, you can get an oxide radical. You can get an oxide radical and all electrophile. And in generation of that electrophile, then this is what is being mopped up, and therefore protecting the body from other drugs. Because remember, these are patients that normally don't take only one drug. And when those drugs are metabolized, there is that generation of very highly reactive electrophiles, highly reactive radicals. Then we have the ropinirole. There's an indolinone. It's an indolinone derivative. If you look at this is the indo, supposed to be indo, but it is indo if it also has double bonds. Remember, the indo must the pyrazolidine ring. It to be an indo, to be a rat. And of course, there will be a double bond there, and there will be a double bond there. So if you look at it, it does not have one double bond. It has that one double bond. It is missing in one double bond. That is why we are calling it an indolinone. It is not a complete indo because it's missing in one bond, indolinone. And then it is an known because of the fact that you can see it has that ketone there. So it's an indolinone derivative and related in structure to the ego lines. But of course, if you look at it, we will be able to establish, as we had said earlier, we are able to establish that it has structural resemblance with dopamine, as we have already said there, and the structure goes that. So it's a slightly bulkier molecule compared to dopamine. Aminonitrogen is substituted with larger groups, as we had said, and therefore giving it higher affinity for the dopamine receptors and dopamine receptor family. So that is the D2 receptor, the dopamine receptor family, where it has D2, can bind D2, 3, and D4. Of course, when it binds the others, it might bring about a bit of toxicity, but it has quite some good affinity for the D2 receptors. It is formulated again as a hydrochloride salt. Remember, we always formulate them as hydrochloride salts to give us good water solubility in the GIT for solubilization or for dissolution and absorption. Then another dopamine agonist is apomorphine. Here's the name, similar to morphine, but it has nothing to do with morphine. The structure is completely different. It's just, it was given a name that resembles that of morphine, but it has no opioid activity. It has no narcotic, or it has no opioid activity at all. Its structure and stereochemistry, if you look at it again, this is the structure of apomorphine, and definitely that's a structure of dopamine. If you look at this apomorphine, you can see we are able to see very clearly, as we were looking at just the same, of course, as for the other agonists. You can see, in fact, this is even more closely related to dopamine. You can see what is in red, and you can see that's the structure of dopamine. So the only major difference, of course, is this other bulk group here, this bulk group there. And bulk group that definitely helps. Mainly, these bulk groups normally do not bind the receptor site per se. They normally anchor themselves slightly outside the receptor to give it good binding, good affinity, and therefore good activity. If they bind too strongly, then the compound borders on antagonism. It could have agonist and antagonism activity. But we are saying this drug has agonist activity, the binding is good enough. So it is a beta phenyl, again, beta just like the others, because if you consider that this is alpha, this is the beta carbon, so the phenyl group is joined to the beta carbon. That's why we call them beta phenyl ethylamine, sharing structural similarities with the neurotransmitter dopamine, and I believe that is very clear. It has a catechol moiety. It also has an ethylamine moiety, of course, substituted. This, of course, is a tertiary amine, unlike, of course, in dopamine, which is a primary amine. That's the main difference, of course. Also, the other difference is that, of course, we have other bulk substituents, but we can't see the backbone. Within apomorphine, we are able to see the backbone of, or we are able to see the dopamine basic structure. The R form is a dopamine agonist, while the S form of the molecule may possess anti-dopaminergic activity. Again, I had already said that if you, because of the extra groups, remember when we talk about the stereochemistry, it is the way that molecule arranges itself in space. So it means that this molecule can arrange itself in a particular way. When it arranges itself to give us the S form, and the S form is the dextrorotatory form, the S form perhaps is more bulkier, and it fits the receptor more firmly. And once it fits the receptor more firmly, it has much stronger affinity for the receptor. Remember, a drug that binds the receptor a little bit more strongly behaves as an antagonist, because it binds too strongly and prevents also the endogenous compound from binding. So that's why we are saying, because of the fact that this molecule is much huger, more substituted than dopamine, depending on the stereochemistry, you can have it behaving as an antagonist or behaving as an agonist. So the stereochemistry, and we have seen stereochemistry in some of these drugs is important, because even when we mentioned, there's another one also we have mentioned, even for pramipixole, we realize that also stereochemistry is important in binding these receptors. Physicochemical properties of apomorphine. And apomorphine has been found to have a bit of challenges in terms of it is rapid, it is unstable, it's also rapidly metabolized. And because of that, when you have a drug which is unstable, rapidly metabolized, it has issues of administration. So those are some of the things that we're going to look at. Physical properties of apomorphine: it is water soluble with an intermediate lipophilicity, and is generally available as the hydrochloride salt. So it has intermediate, or it has favorable. Can't say it has favorable lipophilicity. The hydrophilic character of apomorphine allows it to be solubilized and therefore formulated in as an aqueous solution. So it can be formed once you derivatize it into the hydrochloride salts, and it also has hydrophilicity, because if you look at it, you look at apomorphine, of course, it has to the two hydroxyl groups, and it has the terminal, that group there. Those are the centers of water solubility. So you can't formulate it as an aqueous solution. It readily mixes in the tissue fluids and can be absorbed into systemic circulation and subsequently cross the lipophilic blood-brain barrier. So we are only saying it has its lipid water partition coefficient is favorable enough to allow this drug, one, to be formulated as a solution, and also to allow for the drug to be able to penetrate the BBB and get into the brain. And that is what you need for it to bring activity in the brain. Now you find that when you give patients L-DOPA, they have their on and off times. That it's like there's a time the L-DOPA doesn't work, and they still have the bad symptoms. they have the rigidity, the spasticity, and so on. So during their off moments, even though they are on L-DOPA, sometimes you require to give them an additional drug, especially with time. You know, as the disease progresses, you find that the patient starts developing moments, even if they're on L-DOPA, when it looks like the L-DOPA is not working, and they have the full-blown, all the symptoms of Parkinsonism. So that time is when the time we are calling off, the off time. And during the off time, then you can give them another rescue drug, which can now take care of those the off phenomena. So some Parkinson's disease patients develop on-off phenomenon with a prolonged L-DOPA use of greater than 5 years. Apomorphine, a mixed D1 and D2 dopamine agonist, predominantly finds its use as a rescue medicine to treat the off period in L-DOPA therapy. So you don't just give it as a standalone. You want to use it when necessary, when a patient who perhaps was well stabilized starts developing the on and off phenomenon. The D1 potency by apomorphine is exhibited by the catechol moiety, where the bulk aromatic part of the molecule contributes to affinity towards the D2. Because when you look at it, when you look at that group, that drug, because of those hydroxyl groups, it has the hydroxyl groups, it can be able also, it can be able to trigger, or it can be able to release the noradrenaline, and so on. So it can be able to bind the D1 receptors and therefore behave as the other catecholamines. And like all L-DOPA therapy, apomorphine is administered subcutaneously, and we're going to understand why. In the abdomen region as an intermittent injection by continuous infusion using an infusion pump. This is where now the administration. You see, if this patient requires a lot, as we have said, it has a very short duration of action. So when you give it a subcutaneous injection, if you have to give more than 7 injections to that patient to stabilize, then you opt now to give it as a continuous infusion. So the patient has a small pump and they use it as a continuous infusion. Of course, we do know the disadvantages of these drugs when you have to give them parenterally. There is, of course, danger of infection. You know, this person also is a person which is getting these off moments, is a person who has tremors and so on. How are they going to inject themselves? That can bring a lot of course, there is pain and so on. That can bring a lot of issues on compliance. The avoidance of dyskinesia, so abnormality or impairment of voluntary movement, it has that advantage, unlike L-DOPA. It does not cause dyskinesia, and that's an advantage to this drug. However, apomorphine administration has several disadvantages, such as nausea. It also works on the chemoreceptor trigger zone. It works on the zone which triggers vomiting. And therefore, when you give this drug, you must also give antiemetics, which are often co-dosed. So you must give like domperidone. So that's one disadvantage, that it also has activity the chemoreceptor triggers zone, and because of that, it can trigger emesis, and therefore you must give it in combination with antiemetics. Subcutaneous apomorphine therapy may give rise to problems with patient compliance associated with needle phobia, local pain due to irritation and inflammation, followed by formation of subcutaneous nodules. So these, of course, you know, you have done for a lot of pharmacology. These are some of the disadvantages of parenteral therapy. That, of course, there will be pain on administration. Of course, there could even be infection. And of course, with that, the pain, with the infection, inflammation, irritation, and so on, and that can help, that can lead to a patient, poor patient compliance. Of course, if you have poor patient compliance, you have an issue. This is Parkinsonian disease. If they do not comply, they are not able to inject themselves because of the pain phobia, then the symptoms the symptoms will be precipitated, and hence the patient will have a lot of problems. Challenges with apomorphine therapy, of course, we've already mentioned one or two. One of the challenges is that it has inherent instability, and this poses a complication in clinical practice. And because you see, drugs that have hydroxyl groups are prone to oxidation. So that is one of the inheritors. So oxidation of apomorphine is one of the pharmaceutical challenges when it is formulated as an aqueous solution. Of course, that is because of the catechol group. So readily oxidized apomorphine spontaneously also undergoes oxidative decomposition in aqueous solution to the bluish green color in the presence of light and air. So it can easily, because with the hydroxyl groups, one, even oxidation catalyzed by enzymes. Then also, if you expose it to air, and I believe even when you look, if you have looked at the article A means, I believe you are told even if you have a vial of drugs like noradrenaline, they must be in amber-colored bottles, because on exposure to air, they will undergo oxidation, or exposure to light, they will undergo oxidation. So apomorphine spontaneously undergoes oxidative decomposition in aqueous solution to the bluish green color in the presence of light and air. The catechol group of apomorphine molecules is highly susceptible to oxidation, leading to the formation of the quinone. So that almost is telling us that the problem of apomorphine, as you have seen in structure, is a catechol group, highly unstable, highly oxidizable, both on exposure to light and exposure to air. And of course, when this person is injecting, there is danger that that drug is going to be exposed. And of course, depending also on how they store it. So again, that can bring us some challenges, and of course, poor activity, very, very poor activity. Also, the decomposition of apomorphine is dependent on its concentration as well as the pH and temperature of the solution. So we are only saying that these are factors that will influence the decomposition. Definitely the pH and the temperature are very important. The chemical half-life of apomorphine is very short at physiological conditions, has a very short half-life, about 40 minutes. So if it has a very short half-life, like 40 minutes, that means when you give it, then within 40 minutes, that patient is supposed to inject themselves again. If they are giving it, if they are using it as a subcutaneous injection, and that's why we say preferably you use it as a continuous infusion. The addition of antioxidants, chelating agents, alteration of the formulation, pH are some of the approaches to prevent the auto-oxidation of the molecule. So one of the major challenges of apomorphine is its instability, of course, as we have said. It is because of the catechol group. The 2-hydroxyl group will readily undergo spontaneous oxidation on exposure to air, exposure to light, and of course, once they undergo oxidation, the molecule will not have activity. Number two, another problem is deactivation of apomorphine upon metabolism of apomorphine after administration. So immediately it can undergo fast pass effect, and again it is rapidly, even on administration, it's rapidly metabolized. And because it's rapidly metabolized, it means very little will be available to get to the receptor. So the in vivo conversion also from the R form of apomorphine to the S form. And we have already said the S form has antagonistic activity. So that's one danger, that once you administer this drug, there can be in vivo inversion of the configuration at the chiral center. And once you have that inversion, then you will get the S form. And we have said the S form is mainly an antagonist. Additionally, apomorphine is metabolized via numerous enzymatic pathways, predominantly in the liver, but also in the brain and tissue. So again, it has a rapid, very rapid metabolism, very rapid metabolism via several routes, not one, several routes of oxidation. It can undergo oxidative end dealkylation, oxidation of those hydroxyl groups and so on. So it has several routes of oxidation, and therefore again rendering it inactive. You know, for some of the drugs, even when they undergo oxidation, they still give you molecules which are active, and therefore that gives them a bit prolonged life. But for this drug, the minute it undergoes oxidation, then it is inactive. Some of the metabolic pathways include salvation, that's addition of a sulfate conjugation, glucuronidation, catechol-O-methyl methylation, or catechol-O-methyl transferase, which will give, of course, methylation of the hydroxyl group. Those hydroxyl group can undergo methylation, they can undergo glucuronidation, they can undergo sulfate conjugation, giving this molecule, again, there can be spontaneous oxidation, as we already mentioned, giving these drugs. There can be also inversion of the stereochemistry, giving this drug major drawback and very short duration of activity. It also has a very large another problem is that there is a very large pharmacokinetic variability as reported between PD patients after subcutaneous administration of apomorphine. In other words, it doesn't the responses you get from different patients can be different. It can be effective in one, might not be effective in the other. So this intersubject variability may be caused by the interaction of the drug and its various metabolites with plasma and tissue, which complicates the clinical dose setting because you require stability for these. But we are seeing the pharmacokinetics of these drugs are not standard for all patients. They differ in different patients. So it looks like you should have a specific dose for every patient, which becomes a major problem. So therefore, you are not sure whether the dose that you've given that patient is indeed enough for that patient. So that intersubject variability can also bring a lot of challenges in usage of that drug. The clinical utility of apomorphine upon oral administration is highly limited due also to hepatic. That's the other problem, hepatic fast pass metabolism. So also that add it just straight after the metabolism. So again, it also undergoes extensive hepatic metabolism. Was well absorbed when given orally, but undergoes extensive metabolism in the liver, and therefore whatever is left is very little to get to the receptor. So those are the main challenges that we face with apomorphine. Though a drug that can be used as a rescue drug, then of course it has quite a number of challenges. Parenteral administration of the metabolic constraints account for a poor oral bioavailability in the PD patients due to high apomorphine metabolism. It has a very short plasma half-life after subcutaneous administration. So even when you give it subcutaneously, we have said it still has high fast pass effect, high rate of metabolism, instability because all those challenges give this drug very low or very short duration of activity. It necessitates a high frequency of injections to maintain concentrations of apomorphine in the blood and subsequently in the brain. Continuous subcutaneous infusion may be used if apomorphine subcutaneous injection exceeds 7 to 9 times daily. This we had already mentioned. Because how do you inject yourself so many times? Parenteral administration causes inconvenience to patients with PD and often leads to patient non-compliance. Self-injection might prove difficult for patients in late stage during off periods due to impairment of motor function. So you can see it is a good drug. It can be used for the off periods, but unfortunately, it has its own major drawbacks because of its very short duration of activity. Some of the routes of its metabolism, we have already mentioned, N-demethylation, sulfation, glucuronic conjugation, methylation, and of course, again, methylation through catechol-methyltransferase, non-enzymatic oxidation. The complexities of apomorphine uptake, distribution, and clearance probably contributes to variability of clinical action. So we are saying, of course, it will have problems in its uptake because we are talking about how much of it is available anyway. Its distribution, within its distribution, it could be undergoing again degradation. Its clearance, very rapid clearance, because of course, once you have very rapid metabolism, you will also have very rapid, when you have glucuronic conjugation, sulfation, you have added a lot of oxygens, very highly water soluble, and the drug will leave the body very rapidly. So this is its metabolism. So one of what we have said, inversion of the configuration from R to S, giving us molecules that has no activity. Then, of course, there is oxidation. You can see this is a spontaneous oxidation, non-enzymatic spontaneous oxidation. That is a catechol, and now it is oxidized into the quinone. Then, of course, you can have catechol-O-methyltransferase. You see, you can have this oxygen, either that hydroxyl group or that hydroxyl group can be methylated. And if you have this one, this one. This is number, we are calling that as number 10. If you have the hydroxyl group at number 10, being the one which is methylated, then you get apocodeine. Just as we were saying, morphine and codeine. They are using the same names, but of course, as we have said, these compounds do not have enough. That is the 10, that 10 there. If you get this one at position number 11, being the one which is methylated, then you get the isoapocodeine. So this is apocodeine, this is isoapocodeine. When that is that's why you have that number 11. I put the numbers at least to differentiate. So if that is methylated through catechol methyltransferase, then you get the isoapocodeine. Then, of course, there can be conjugation. It can undergo sulfate conjugation, it can undergo glucuronic conjugation, and of course, once those compounds are formed, that molecule will be removed from the body. There can be also oxidative end dealkylation. You see this also, as you remember, we did mention that also. We say there can be end methylation. So this group also, so there could be another arrow coming down whereby you have oxidative end dealkylation, and that becomes an NH. And all those metabolic processes are result in molecules that do not have activity. And like other dopamine agonist drug, which are taken as tablets or patches, apomorphine must be given subcutaneously, all as continuous infusion using a pump, as we have already mentioned. It must always be prescribed by the brand. In other words, this is one drug that when you stabilize a patient on a certain brand from whatever company, you cannot change that brand. If you change that brand, you will have a lot of issues because it might have a different rates of metabolism and therefore giving you a lot of problems. Avoiding confusion and to ensure the patient always receives the same product. So you must always prescribe it as a brand. This is because, of course, if we did not, of course, we know different brands, though they have the same content and quality, sometimes they have differences in their release mechanisms. They have some slight differences. One might be released rapidly, another one very slowly, and so on. So we are saying brands are not interchangeable. You give only one brand. Continuous infusion is when medication is delivered via a small pump, non-stop into the body. And you do have some formulations that are available. And of course, these are things that you do better in pharmaceutics. So you have the subcutaneous injection, subcutaneous apomorphine. You have a multiple dose pen injector. So again, subcutaneous apomorphine, the pen injector, and also you have the mini pump syringe driver. So you have all those. You have those three different formulations, and of course, the patient will use what is best for them. And that finalizes the apomorphine. As I have said, it is a good drug which is used as during the off period or on and off phenomenon, especially now during the off phenomenon when the patient is already on levodopa, but unfortunately they are not responding. We also have now, we move on, we also have another agonist, lotigotine patches. This one is, as you can see, it is lotigotine patches. So this is one drug that we are able to use as a patch where you just apply it on the skin. So it is a non-egoline, again, dopamine agonist. It is formulated as a once daily, very good transdermal patch, which provides a slow and constant supply of the drug over 24 hours. But I must believe, I didn't check, but I want to believe it must be very expensive. These patches, patch ones must be quite expensive. And of course, with the economy, the way we have the economic stress, I don't know whether we can be able to afford some of these drugs. Very few of our patients can afford. It is an aminotetraline derivative, and this is what we call the aminotetraline here, where you have that phenyl ring joined to, of course, this is a cyclohexene ring, because this here there is unsaturation. So when they are fused together, That is the aminotetra. And of course, there is amino group. That is what you call the aminotetraene, or the tetrahydronaphthalene. Tetrahydronaphthalene. It's tetrahydro because you'd be having a double bond there and another bond there. Maybe it was actually naphthalene. But now you don't have that bond there, there's saturation, and therefore that's why we are calling it tetrahydronaphthalene. And you can see that it has that group there. Of course, it has the amine, so that is the aminotetraline. We are calling it aminotetraline derivative. Hepatic. It is extensively and rapidly metabolized by conjugation and then dealkylation. You can see this nitrogen there. It has this group there, which is an alkyl group. It has that group. So this group and that group can undergo end dealkylation. And of course, let us look at its metabolism. I hope you can see this. I don't know whether you're able to see this. So we start with our drug is here. So this is our drug here. Orthigotine, our drug is there. And we are saying it can undergo N-oxidative and dealkylation. And remember, it's an oxidative process. So it's catalyzed by cytochrome P450. So it can undergo oxidative and dealkylation. And it can lose this group. So the first oxidative and dealkylation is where it loses this group there. This group. If it loses that group, to form this. So that group is done. Oxidative and dealkylation catalyzed by mixed function oxidases. Then it can also undergo another oxidative. It can also undergo oxidative and dealkylation, where it can lose the whole of this. This is the thiophene alkyl group. You can lose the thiophene alkyl group now, and again catalyzed by cytochrome P450 enzymes, and you can see simple. It's only that group that has gone. So now this other group is left. Right, so that is the first metabolic process, oxidative and dealkylation, to lose either the thiophene alkyl group or to lose the the propyl group. It can undergo also sulfate conjugation. Sulfate conjugation catalyzed by sulfur transferases. So that again, it has a hydroxyl group there that can undergo oxidative or can undergo sulfate conjugation. The same group can also undergo here glucuronic conjugation. So it's simple metabolism, really. Then this group here also, which has undergone oxidative and dealkylation, can also undergo glucuronic conjugation and sulfate conjugation. This group here, which also has, because of the hydroxyl group, which has undergone again oxidative and dealkylation, can undergo sulfate conjugation and glucuronic conjugation. So the main route of metabolism of this drug, we are calling rotigotine, is oxidative and dealkylation, sulfate conjugation, and glucuronic conjugation. And you can see, I think it has quite a simple structure, which where we can be able to see. So that again finishes the various groups of dopamine agonists, starting all the way from the naturally occurring, the bromocriptine, the pagolides, and so on. And then we go to the others, the other ergoline derivatives, we go to apomorphine, and finally the rotigotine. So those are the dopamine agonists, which definitely will act like dopamine. Then also we have the other class of drugs, which we are calling the metabolic protective agents. Metabolic protective agents, some of them we have mentioned them. These are the drugs that you give to prevent the dopamine from undergoing metabolism. So all you need to understand, what are the different types of metabolism we have for dopamine?